Thank you, Dr. Agarwal, for giving me a chance to speak on a very common problem, but very difficult solution at times. I am going to talk about a new technique which is called video-assisted anal fistula treatment. In this technique, there is no cutting involved, there is no post-operative dressings. One is quite comfortable. Now, this is just my current appointments: Nova Medical Center, Paris Spring Meadows, Apollo, Max, all these places. And definition everybody knows about. I'm just going to cut it short. I'll show my video presentation so that one can see the technique. We all know anal fistula is an abnormal tract of granulation tissue which communicates between anal canal and rectum and the perianal skin. Normally, anal gland drains into anal canal. If outlet is blocked, then this results into abscess and points to skin surface. Tract formed by this is called a fistula. The symptoms usually there's no harm, but they usually don't harm, but there can be a painful tender swelling, irritating due to pus discharge, bloody and purulent, recurrent abscess formation, systemic spread or infection. They are low level or high level, we all know. There are various types: submucous, low anal, high anal, pelvirectal, transsphincteric, supralevator. This is all classification. The possible finding by examining is there can be multiple external openings, red tender swelling, area of induration, discharge or pus, skin excoriation. Digital examination tells us internal opening, palpable as a nodule on the anal canal wall, irrespective of external opening, and there is only one internal opening. Then the hallmark of the treatment is to close internal opening, take care of the tract, not to damage the sphincter, stop recurrence. Now this is the technique which I am going to talk. I'll show you the video of this technique. I'll just come to this is the video presentation which I am going to show you now. This is the fistuloscope which we are using, and this is the monopolar cautery lead which I am using. This is a brush by which we clear the fistula tract. This is a proctoscope, irrigating tube. All these are the parts which are used. This is the complete system fistuloscope. This is the fistulous opening at about 6 o'clock, and through the external opening I push the fistuloscope. You will see. This is the irrigating fluid, and this is how I push the fistuloscope into the external opening, and we will see clearly the fistula tract. At times I push this rubber catheter to dilate the fistula tract also, because the fistula tract is fibrosed, stenosed at times. With this we just dilate it. And now you can see I'm just pushing this fistuloscope, and you can see that clearly, red light, you can see clearly this fistula tract. And this is the internal opening. One can see it's about 6 o'clock. This is the complete tract which one can see. This is starting from external opening going inside. Now you can also see clearly, once we push the irrigating fluid, we will see the irrigating fluid coming out nicely here at about 1 o'clock or so. There will be gush of fluid only, not blood. One can see clearly. Normally this kind of internal opening is not seen in open surgery. We go blindly, we just push a probe. Now you see here one can see how clearly the fluid is coming. And this is the fistula tract which we normally see after passing the fistuloscope. This is all the slough tissue, the granulation tissue, all this is seen in the fistula tract. And this fistula tract is distended by the glycine irrigating solution, which is continuous irrigation. Now this whole fistula tract has to be coagulated with monopolar cautery. This is coagulated centimeter by centimeter by taking care not to damage the telescope. This all is the fistula tract. This is slough tissue, necrotic tissue, granulation tissue. This is all mixture. I mean, you can see clearly how nicely we can see the fistula tract here. This is again the fistula tract being shown. Now we're using the monopolar cautery. This is a rounded tip, and you can see clearly how the coagulation is being done with this monopolar cautery. The whole track is coagulated with this monopolar cautery. This all is the coagulation which is being done. We always take care that we don't reach the rectum. That's why we put a finger in the rectum, and we coagulate the track all around, on all the places, centimeter by centimeter. You can see this whole area is coagulated, and we keep coming proximally, and the whole track is coagulated. This after the coagulation, whole track looks like a charred necrotic tissue filled track, and this whole necrotic material is removed either by simple curette or by that fistula brush. This is that brush which we use to clear the track. Now this, you can see how we use how I'm closing the internal opening. This is the internal opening side. Yeah. This is vicryl I am using, 2-0 vicryl. This is the site of internal opening. I close the internal opening with vicryl. Then after that we use this linear stapler. You can see this, the internal opening is lifted and this linear stapler is applied to the internal opening. So this is kind of double layer closure. The first is with the vicryl, the second is with the linear stapler. This stapler seals and cuts the whole tissue. Finally the picture is like this. And this is a curette I'm using to clean the necrotic tissue from the fistula track. This is used all around and the necrotic tissue is removed. And also this brush is used to clear the track, and this is the final tissue which is removed. And in the last we use fibrin glue, which is mixed and takes about 5 minutes to prepare. We push this fibrin glue into the track, so the track is sealed. Nowadays, I also use acrylsanolate, which is a better and cheaper product than the fibrin glue. With the help of this catheter, I push the fibrin glue. And after this, the procedure is complete. And there's another case. I just want to show you the internal opening in that case, how one can see clearly the internal opening. In this case, the external opening is here at about 1 o'clock, and I just want to show how clearly internal opening is seen. So as a result, one can see that there's no cutting involved, there's no damage to the sphincters, there's no post-operative dressings. One is very comfortable. One can resume the activity very next day. This is a direct track going to the 1 o'clock position. So I'll just show you the internal. This is again the fistula track, how it looks when we push the fistuloscope. This is again granulation tissue, necrotic tissue all around, one can see. It is just another 10 seconds. There's just one thing I want to show. See, these are again, at times we also encountered some associated pus cavities along with this fistula track. We also coagulate those pus cavities and take care of these associated tracks also. The other advantage of this technique is that all the other side tracks now here is the internal opening which I want to show. You'll see clearly. You can see clearly the water coming. At 1 o'clock, we push it from the external opening. One can see clearly how nicely one can see the internal opening. Yeah, here. That is the internal opening. So again, rest of the steps are same. And this is again the coagulation of the track which we're doing. And the advantage, several other options are doing nothing: lay open of fistula, cutting seton, fistula plug, fibrin glue, endorectal flap, and lift technique. Advantage of this technique is this day cure surgery, no surgical wounds, there's no dressing required, accurate localization and closure of internal opening, fistula track is completely destroyed, No need to know if fistula is high or low, no fecal incontinence, no pain, no medication required more than 7 days. Can go back to work within 48 hours, economical. No, that's over, we have already talked it. That's it, that's about my presentation. These were the all other things. Thank you, sir. Thank you very much.